Now, Marie's favorite technique is fixer-assisted nailing and plating. Deformity correction using internal lengthening nails is actually my favorite technique. Or I like to call it the slinky technique because you're working both on deformity and length at the same time. So historically, when dealing with a problem like the one you see on the left with a deformity, a shortening, a non-union, you didn't have that many options, right? So patients who didn't want surgery had access to a shoe lift, but otherwise, external fixation was mainly the main course of action. With the arrival of the novel internal lengthening implants, or not so novel anymore, it gave us a lot more comfort, or gave the patients a lot more comfort in their lengthening rather than having the, as Professor said earlier, unethical external fixator of the thigh. Now we can give them a lengthening option that's a lot more tolerable. I had a discussion outside with a surgeon. What's the sequence? Should we lengthen first? Should we correct the deformity first? Should we lengthen second? What's the best option? This is a case that I did with Dr. Herzenberg, I think my first month into practice. A young gentleman with a valgus deformity and a leg length discrepancy where we did a sequential lengthening and then deformity correction with the benefit of being as accurate as we can at every step of the way. The downside is it's two different surgeries, right? So we submit this patient to first a lengthening and a hardware removal, then a deformity correction, then potentially a third surgery for a removal. What I like to present today is actually a simultaneous single-stage correction of the deformity plus lengthening with an intramedullary nail, with the benefit of being a single stage, but the downside of requiring a lot more accuracy on your end to be able to avoid under or over correction. This was a 50-year-old gentleman with diabetes with neglected tibial plateau fracture, bicondylar tibial plateau fracture, was complaining of a 3 centimeter leg length discrepancy and genu varum. He was offered a knee replacement at another facility, but this would not address the leg length discrepancy. So I chose to do an acute valgus-producing osteotomy of the proximal tibia with a precise lengthening, which is a magnetically activated lengthening device to achieve both neutral alignment and equal leg length. So in my practice, the indications are going to be a uni or multiplanar limb deformity with leg length discrepancy with a functional impairment. Now, in that, I put a little asterisk because body image should never be discounted as a functional impairment. And finally, failure of conservative treatments, right? Shoe lifts are great, but we don't wear shoes every hour, every day. I try to avoid it in patients with severe comorbidities, vascular problems, poorly controlled diabetes, patients who might not be able to tolerate the treatment psychologically or physically. This is a 25-year-old male with a history of distal femoral growth arrest in his youth. If you look at the x-ray completely on the right, try not to get an x-ray like that. My recommendation would be to always balance the pelvis using shoe lifts. So this patient would get a good physical exam beforehand, establish his functional leg length discrepancy, and get an x-ray with the actual lift. This x-ray was taken in another facility. So we have a 3 centimeter leg length discrepancy and lateral knee pain. So what do we do first? Map the ABC. We always go back to the basics, right? So we find that he's in valgus with a laterally deviated mechanical axis. The culprit is the left femur with an LDFA of 77, and all the other bones are normal. And when we measure the bone lengths, we find that the leg length discrepancy is in the femur as well. So now we decide to pick the femur as our correction. And this is a very similar case as the one you showed me right outside, doctor. So next step, we find the apex. And what I did is I used the 3-line method proximally to find the proximal desired mechanical axis, and then I extended the tibial axis distally to find the apex of the deformity, and I found an apex of deformity at the distal femoral physis. Just as a reminder, those are your normal values. And technically, here's how I will execute this case. The first thing I will do is establish where I do the osteotomy. In this case, slightly above the joint capsule, but away from the apex. I drill the holes with a 4.8 millimeter sharp drill bit, and I will apply the temporary external fixator that Dr. Gedalovich talked to us about. The proximal pin will be in the lesser trochanter, away from the path of the nail, and the distal pin will be in the distal metaphysis. I like to put it posterior to the nail. Marie likes to put it anterior, as long as it's outside the path of the nail. Then I will cut the bone, do the osteotomy, and get my correction. And here you can notice that sometimes when you do an osteotomy, there's a wedge fragment that breaks. It's not a big deal. You just have to be careful. And then I check the mechanical axis intra-op, and I'm looking for a neutral mechanical axis. Once that's done, all I have to do is a regular nail, right? Retrograde nail. So find the entry point with a wire, ream the canal, insert the rod, and then apply the appropriate blocking screws that will prevent problems postoperatively. Last but not least, you do not want to leave the operating room without knowing that this implant is working. It's a simple test. It takes about a minute with the remote control, and you see that the machine is working either because the washer is moving, because this counter torque bar is also moving, or because the space underneath the mechanism is widening. So 3 different ways to measure that. So this is the same patient 6 months into after his lengthening. He's now fully healed. He's got even leg lengths, and his mechanical axis matches the other side. You can use the reverse planning method described by Baumgart to know how exactly to plan so that despite having a long lengthening, you can still end up with an accurate mechanical axis deviation, because remember that once you're lengthening, you have a moving target. So the reverse planning method helps preventing over or under correction. You can also achieve very good rotational deformity correction and lengthening using these nails. Those are the easiest. So this is a 34-year-old woman. She has a 40-degree external foot progression angle, 2 centimeters of leg length discrepancy following a proximal third femoral fracture. On physical examination, we use the thigh foot axis to measure the tibia rotation, and we use the hip rotation, internal and external, to measure the version. It's not this patient, by the way, but this is how we measure clinically the rotation. I like to use a CT scan to double check my physical exam. If the CT scan and the physical examination do not match, I trust the CT scan more. My partners do not get a CT scan routinely. It's just in the US, it's easily accessible. So in this case, we found an excessive retroversion of about 30 degrees. So all we had to do was that fixer-assisted rotational correction with the gyroscope or the sterile level. And as a rule of thumb, my recommendation is to overcorrect rotation. When you do a deformity correction over a nail, even with a lengthening nail, overcorrect by about 5 degrees, because there will be a bounce back. The natural tendency of the soft tissues is to bring back the leg in its original position. And this is what she looks like once fully corrected. Intra-op, you can use, when you do a pure rotational correction, yes, you can use Schenz pins, but you can use as well thick Steinmann pins. It's less expensive, and it will give you the right result, the same result. Just make sure that they're thick enough that under the tension of soft tissues, they will not start bending. So on your left, it's before the deformity correction is done. They're divergent, give or take 15 degrees for this specific patient. And once the correction is achieved, before you lock the nail, you make sure that they're collinear, and you've got your deformity correction. Alternatively, if that doesn't work, an external fixator can be a good option. Now, there's a lot of pearls, there's a lot of details that have to be applied when doing such a correction, because every detail matters, from the entry point, the osteotomy level, the positioning of blocking screws, and even latency period. When doing an acute deformity correction and lengthening, if your entry point is not perfect, you will start lengthening in a vector that is wrong. And you have to match intraoperatively your planning. I like to use Bone Ninja to establish where the entry point will be, and I try to recreate that intraoperatively. Osteotomy level is also very important. You establish it with the MAPD ABC. You want to cut very close to the apex, because if your osteotomy is too far from the apex, physically you won't be able to implant the lengthening nail, and it's going to become a problem. Also, beware the osteotomies that are too close to the joint, because they become very, very difficult to manage. They become very, very difficult to control. And even with perfectly placed blocking screws, you'll end up with valgus deformities and apex anterior deformities, which is a perfect segue to talk about blocking screws. In this specific technique, blocking screws have two roles. Role number one, they are resisting your deforming forces. As you lengthen, there's no way to remember that other than just memorizing it. In the distal femur, the apex anterior and varus deformity is the most common, so you have to put a blocking pin medially and posteriorly, while in the proximal tibia, it's more valgus and apex anterior. In a diaphysis, you don't need blocking screws, right? Your diaphysis acts like a train track. However, those are necessary, mandatory, obligatory in metaphyseal lengthenings. And finally, the second role of your blocking screw is also to prevent recurrence of the deformity. So you want to think not necessarily in terms of the resisting forces, but as well, what does the bone want to do? It wants to go back in its original position. So this is the first example of blocking screws positioned for retrograde lengthening. And what I tell my residents is, if you're not sure if you should put blocking screws, add it. Right? So in this case, the most necessary blocking screws were medial and posterior. But then my resident asked me, should I put a blocking screw laterally? And my answer was, yes, you should. Why? Because why not? We've seen patients kick back in the opposite direction because of premature walking or just instability of the fragment. So you never go wrong with strong. And this is an example of blocking screws well positioned laterally and posterior to the nail to prevent apex anterior and valgus deformity. Now, what happens when you break the rule? This was a case I did about 5 years ago, and intra-op, I failed to notice how much space there was in that proximal fragment, and I thought, you know what, there's a good isthmic fit. There was no good isthmic fit. So I put a blocking screw here medially. I put a blocking screw posterior, but I failed to put one on the medial cortex. And as the patient lengthened, just like we call that the Bell effect, where the nail, as it lengthens, goes and hug the medial cortex. And this patient ended up in varus. On the left, that's not my case, that's a case I inherited, but it's an example on how if you fail to put a blocking screw because you don't have metaphyseal contact, then you end up with a varus deformity, an opposite deformity. Finally, when doing an acute correction and lengthening, especially in older teenagers, younger adults, or older adults, increase the latency period. Because you've disturbed the callus, you've disturbed the hematoma. And you got to make sure that you give plenty of time for the body to create that hematoma. So in my practice, in adult patients in the femur, I won't hesitate to go from 10 to 14 days of latency period. And sometimes in the tibia, up to 21 days. I could even show you cases where I waited a month before starting lengthening, just to make sure that callus formation would be good, regenerate formation would be good. The second thing is slow down. Except in pediatrics, premature consolidation in most adults is not a thing. Our enemy is delayed union. Complications are numerous and can be devastating. They can range from poor regenerate, delayed union, premature consolidation. As I mentioned, under or over correction are very common, and that's something that has to be mentioned to the patient. If you want the most accurate treatment, get an external fixator. If you want comfort, you have to accept that we can be 1 to 2 degrees off in any direction, even in the best hands. Contractures, neuritis, or fracture. This is an example of a tibia lengthening where I thought I was super sleek by putting a blocking pin in the distal fragment. Lo and behold, there was not enough room, and the distal shaft broke lengthwise from the osteotomy all the way down to my little plate right there. And as a result, regenerate was really poor. And finally, implant breakage. I think it's extremely important to warn the patients that these implants are made out of metal, and they can only tolerate a certain amount of weight bearing, no more than 50 pounds, which is 22 kilos in metric. So this is an example of a broken housing and broken rotational control mechanism, which is devastating. Finally, quick little word on bone transport. There are internal bone transport nails that exist, that are on the market. They're wonderful because they prevent years, up to a year and a half inside of an external fixator. They're still somewhat experimental. There's not that many cases that were done worldwide, but they're very promising. This was the example of my very first case of a very, very proximal lengthening, which I could not control with the blocking screw, that drifted into valgus. So another example on how osteotomies or bone transports that are very close to the joint are harder to control. So in a nutshell, acute deformity correction and lengthening is a wonderful alternative to circular external fixation. It's a lot more comfortable. However, it's unforgiving. It's technically challenging. The learning curve is real, and you just have to focus on the details. And as my pal Rob Rosbrook used to tell me, the devil's in the details, Michael. Thank you very much.